Microphone check. 1, 2, 1, 2.
committee meeting order. I like to use the gavel. We'll go ahead and start with any citizens wishing to address the committee. Is there anyone here today? Was there anyone agendized? Okay, so we will continue going on. I just need approval of the minutes from our last meeting on May 13th. Can I get a move for approval?
Move approval.
Can I get a second?
Second.
Okay. We'll approve the minutes today. All right, as always, we usually start out the committee meeting with Dr. Carla Pudi and Dr. Badamosi sharing a patient voice. So these are shared by our patients, and just to highlight and kind of realign our true north and the reason why we're here. And so, Dr. Carla Pudi.
Thank you, Madam Chair. Thank you. Good afternoon, Board. It's always a pleasure to be here. We in quality take quality improvement very seriously, and we are applying the same principles of quality improvement of Plan, Do, Study, Act to the board agenda. We have received your feedback, and we are trying to make these meetings more relevant and beneficial to the board and the institution. So one of the feedback we received is that there needs to be additional information that's more granular, that provides more context to the extraordinary breadth of quality work that happens at JPS, while providing the committee a broad oversight of what the institution performs. So in order to find that balance, you will find that this month's agenda is different than the prior months. This month, you will actually hear more granular information from our quality programs that are going to happen after the Golden Mid Awards. I wanted to provide that context before we get going because it's new. And as always, the quality department is committed to improvement. So after this, if you have any feedback for us, let us know, because the only thing that we do is improvement. We'll get better and better after every meeting. And hopefully, our hope and aim is that after a few of these meetings, you as the board have received both a comprehensive overview of quality, but also have received more granular insight into specific programs. So with time, the hope is that that balance would be found. With that, I would love for somebody to start sharing the patient voice story. This is an amazing story. It's a bit long, but bear with us, it is worth the long story. So, Derek, we are ready. It's not Derek, it's me.
Hacemos todos los martes lo del food pantry, que pues se les da comida a la gente. Eso es lo que hago aquí. My name is Roxana Bonilla. I'm from El Salvador. I was active, playing sports in school, volleyball, all of this stuff. I was running the tracks, and I felt the shortness of breath. To me, it was, I guess, normal. Until all my coworkers, are you okay? You sound this, you sound that. Then my sister said, you sound like you have asthma. She was the one that motivated me to try to get the lungs checked out and see what was going on.
So what condition she has is, we call it as tracheobronchopathia osteochondroplastica. This condition is genetic, and it slowly progressed for her, leading to worsening shortness of breath. What I was expecting based on the CAT scan is that, yes, she would have some narrowing of the trachea, some calcified nodules I would see, but to this extent, I have never seen before, or never even seen pictures or literature about this extent of the disease. And that's why we had referred to other places.
So I was like doctor to doctor. The first doctor that saw me, it was a lady. It was in Dallas. And she's like, no, I'm going to refer you to another doctor. So she did. I went to the doctor. He charged me like $8,000, $9,000, just to do the same thing Dr. Patel did. What happened was I came out worse than when I went in. And I got concerned. So my mom came and she's like, I'm going to take you to Houston. So we did. I went to Houston. I took all the packages, that I have. And they say the same thing.
I had even shared her pictures of bronchoscopy to different places, and everybody said, hey, this is a very challenging case. Nobody was willing to do anything to her.
So I talked to Dr. Patel and I said, you know what, I give up. The doctors, I went here, and I can't find somebody to do the procedure or the surgery that I need.
Seeing her in my clinic right here on this chair, over days and months, her symptoms are getting worse. If we didn't do anything or we didn't offer her anything, she would have nothing left.
He talked to me, he's like, I can do it. I was like, I trust you, so do what you think is best.
That's the time, I consulted Dr. Wickwire from ENT and asked him if he could do a joint case.
We were able to meet in the middle and give her kind of a full tracheal or full windpipe treatment that helped her breathe considerably better. We started with kind of a conservative intervention, primarily focusing on the upper part of her airway, and then she did really well from that, proved to us that we were able to keep her safe during the surgery, and so we took her back about 6 months later to repeat the process and give her a more holistic, comprehensive treatment of her airway.
I think I'm able to walk now a long distance without me getting tired, short of breath. Even playing with my kids. I want to be there for them. I want to do things with them, play. And if I didn't take care of this, it was not going to be, possible.
And for somebody who has given up hope to get hope restored is tremendous. And that's rewarding too for us to be part of that journey and to see the light come back into somebody's eyes and say, yeah, maybe there is hope for me.
It makes you really happy when you see somebody, who cannot breathe and now is able to breathe and do her normal work and everything.
It's one of the most satisfying parts of my job is working with patients like Roxana.
I will not, I would say, have my life back without them. Dr. Patel and Dr. Wickwire and all his team, Dr. Patel's nurse, everybody was willing to help, and they treat me really good. So that's all I can say.
That's what the biggest motivation, biggest drive for me is, the happiness, the joy on the patient's face. That they get better, they can go home.
I can assure you today, right now, in one of our clinics, that story is being played out by another patient, by another physician. This happens every day at JPS. After 20 years, I finally found a term that I did not know, and 6 words that are purely in Latin that nobody can understand. And this is a place they come after they fail many other places. It was a phenomenal testament to the care that we provided that patient and Dr. Patel. So that I'll hand it to Dr. Badamusi.
Thank you, Dr. Kalapodi. Good afternoon, board. Good afternoon, Dr. Holland. For the month of May, the Golden Mate Award will be presented to the emergency department. If you've been around JPS in the last several months, you know our patient intake and volumes have gone up significantly. They have handled it remarkably well while still prioritizing quality and patient safety. For this reason, they have won the month of May 2024 Dr. Charles E. Weber Golden Mate Award. And this award will be presented to them next week with the other winners from June and July. Thank you.
Excellent.
Yeah. Next, I will be calling on Elizabeth Rogers to present the quality programs.
Good afternoon. Hi, I'm Elizabeth Rogers, and my group is coming up, and we got an exciting presentation for you today. At least we think it's exciting. And whenever I see those videos, I always have a hard time not crying. I've worked here for 23 years, and I'm always still taken back by the good work that our staff do, from physicians all the way down to our patient care assistants. So thanks for sharing that. Okay, so today my title is the Director of Clinical Services, and today we are sharing the work of Nursing Clinical Services. To my right is Kathy Watts. She's the Manager of Nursing Clinical Services, and we are a group of specific patient disease and population-specific programs that focus in on patients and try to have better patient outcomes. So I'm here today to highlight our inpatient Joint Commission certified programs. So these are all certified by the Joint Commission, and they were all recertified in June. One of these programs, Patient Blood Management, is an advanced certification. And the other two programs, myocardial infarction and sepsis, they are certified under the Joint Commission category of disease-specific. These programs, oops, I think that I forgot I had a thing here. Okay, so these programs are certified every 2 years by one surveyor over 1 day. There you go. I'm sorry. I didn't realize I had a clicker here. So, just a little bit of history. In 2002, Joint Commission launched the disease-specific certification with evidence-based structured criteria to help hospitals build high-quality, patient-centered programs to improve patient outcomes. JPS received its first Joint Commission certification in 2007, and then also in 2016, 17, and then our last one was in 2022. These certifications are very important because the rigorous Joint Commission requirements promote patient care excellence. Each program coordinator leads an engaged interdisciplinary team that owns all the patient care processes. These teams include physicians, nurses, respiratory therapists, physical therapists, dietitians, EMTs, patient care techs, and other disciplines also. The interdisciplinary collaboration and the standardization of policies, procedures, and care pathways require high-quality clinical service. In addition to the work of the interdisciplinary team, the program coordinator and the clinical RNs closely monitor all the patients that are in these categories to ensure the certification standards are upheld and that the clinical practice guidelines are followed. As I mentioned before, the Joint Commission surveys these programs every 2 years over 1 day. During these surveys, the surveyors look at all aspects of the programs. They go through patient records, a sample of patient records, and they talk to the staff. And I'm happy to tell you that in June, all of these programs were recertified, and the Joint Commission found nothing. They were perfect certifications. So I'm very proud of them, and today they're going to have a chance to talk to you about what they do to ensure excellent patient care. So I want you to meet them, and I want you to hear about their programs. But before I do, I want to recognize Kathy Watts again, because she is the driving force behind these programs. So we are going to start with Tessa Watkins. I'm sorry. Watson, and Dr. Patar. And this is patient blood management.
Thank y'all for allowing us to be here today. We're so excited to show you our program. So I'm Tessa Watson. I'm our patient blood management program coordinator. In the back of the room, though, I do have my counterpart, Jody Primero. She's our clinical resource specialist, and she greatly supports our program. And then our newest medical director and champion here is Dr. Sunny Patar. So we're excited to welcome him as our medical director. I do want to give you a brief overview of our patient blood management program. So our patient blood management program is a multidisciplinary, proactive approach to make sure that we optimize the patient's own blood, prevent any blood loss and any unnecessary blood transfusions to support patients who may decline blood products. We're averaging over 1,000 products transfusions per month. And patient blood management is important because while transfusion can be beneficial and life-saving, there are associated risks with receiving a transfusion. By using a proactive approach, we were able to improve our patient outcomes by reducing complications associated with donor transfusions, contributing to a decrease in length of stay, and maintaining efficient utilization of blood products to support our community blood supplies. We ask our physicians to continuously support patient blood management by using our evidence-based guidelines and anemia protocols that serve as a guide for the assessment and management of patients with low red blood cells or anemia, risk of bleeding, or those who may decline a blood transfusion. Using these practices, we've consistently maintained a reduction in blood product usage, which you'll see on a later slide, and we have contributed to improvements specifically in our maternal patient population. By monitoring the maternal patient transfusions, we've supported them to anticipate the care needs for moderate to high-risk patients of risk of bleeding and having an adverse outcome. To improve their care and recovery, we support those patients with pre-delivery blood allocation, iron supplementation, medications, and devices that reduce the bleeding during and after their deliveries. On this slide, which we're really proud to show you today, we've had, since our implementation of our program in 2019, we've been able to decrease our blood and blood product usage by 24%. That blue line that you see there is our average patient volume days for inpatient and our observations, but the red line is the volume of our transfusion rates per those 1,000 patient days. So despite the increase in our patient volume population, we're still having a decrease in the overall transfusion rates for our patients. And then as a strategy not to transfuse our patients, we implemented the use of Cell Saver. Cell Saver is equipment that we use in our operating room to collect a patient's own blood during surgical procedures and return it back to them to reduce the need for blood donor transfusions. And since we've implemented this and since 2013 or 2023, we've seen a cost reduction in $175,000, but more importantly, that's over 800 units of packed red blood cells or transfusions that were avoided in our patients. And our newest initiative is for our sickle cell identification for patients. In May of this year, we enhanced our medical record to identify patients with sickle cell disease that have a transfusion request. Our goal was to make sure that we improved our transfusion safety for those individuals. But unlike general anemia, which can be managed with supplements, sickle cell is an inherited trait in which the red blood cells sickle or form crescent shapes. Those cells build up in our blood vessels, blocking blood flow and causing pain and potential organ damage for these patients. Sickle cell disease requires more intensive treatment and frequent transfusions and close monitoring. One of the side effects that can occur with that is alloimmunization. Alloimmunization in sickle cell happens when the person's sickle cell anemia reacts with the blood transfusions from donors, and their immune system reacting, making it harder for us to find compatible blood for future donation requirements. They also, with those frequent transfusions, since blood is rich in iron, receive with repeated transfusions, the iron builds up in their organs, compounding their organ damage, specifically in their heart, liver, and other areas. We do have medications that we can use to remove that excess iron, but again, it requires dedication and a focused team to manage those patients appropriately. Newest achievement here, we were certified originally in 2022, even though we began our efforts in 2019. We are received a level 1 patient blood management certification from Joint Commission, and that goes beyond monitoring of our transfusions and recognizes the activities across our entire network that support patients in optimizing their own blood. This included our iron and blood transfusions in our outpatient community health setting, our pre-surgical optimization clinic to reduce surgical complications, and supporting our patients who decline blood products by partnering with our hospital liaison committee for Jehovah's Witnesses. We use the Cell Saver in our operating rooms to return that blood back to our patients. We are the only PBM protocol in Texas and one of 10 in the nation that puts us in line with Johns Hopkins University, Georgetown University Medical Center, and the Mayo Clinic. No questions. I will now pass it over to Chrissy Feinauer. With our
I actually
AMA.
do have a question on this. So for your sickle cell patient population, do you have a hematologist following these patients?
We do not have currently a dedicated hematology team that follows those patients. That would be a future goal for us, is to have a dedicated hematology team and a case management team to follow those patients. But we do have referrals that go in our anemia protocols to make sure we get those referrals to hematology.
It's a dearth in Tarrant County. We don't have any hematologists, period, that follow sickle cell. So
Yeah.
it's nice to know that we're at least recognizing them in their hospital. So thank you.
Dr. Patar, do you want to say anything? It's always nice to have our...
Well, I appreciate being here, and just want to point out the amazing job that Tessa has done. I am relatively new, kind of catching up to all the strong work that Tessa and her team have been doing, and Jody, I know she's back there, but I'm kind of excited to see where we go with this in the future, and I know I've got a really strong team with me here. So.
Can you also just elaborate the Cell Saver program? So do the patients come in prior to surgery to donate their own blood, or how do you collect it?
They do not. It's actually
During the surgery.
During the surgery, we can collect that blood and spin it down and return it back to their patients.
It's very cool.
That's really cool. Yeah. Where do you use this a lot? What is it in the orthopedic surgeries?
We see it more in our orthopedic surgeries, but primarily in our cardiothoracic surgeries too. Those patients are specifically at risk for having a low blood count.
What about gynecological surgeries or?
I've started using it in our obstetrics area, and they're looking at expanding and getting another unit for those patients that are maybe not an emergent situation, that we can plan them coming through so that we can return that blood to them. A great program. This month they've had our initial goal was monitoring blood transfusions or cell saver devices for blood transfusions over 750, and they've met that at 100% this month. So we're really doing great with that.
All right. Good afternoon, everyone. As Tessa mentioned, my name is Chrissy Feinauer. I am the coordinator for the Acute Myocardial Infarction Program. I also want to introduce you here. I have Dr. Juzar Lakanwala. He is the medical director for our program. I just want to give huge thanks to Dr. Lakanwala and Dr. Patara. I have many physician champions that provide so much engagement and support for us. So just a brief overview about the AMI program. So AMI simply means heart attack. The goal of our heart attack program, the goal of our heart attack program here at JPS is to reduce the incidence and severity of our heart attack patients in our community through early detection, effective treatment, and education. We aim to improve patient outcomes by providing timely, high-quality care, promoting lifestyle changes, and ensuring access to ongoing care and support. Our heart attack program is so important because time is muscle, and that heart muscle dies very, very quickly. And it's vital that we open up that blocked artery and get the blood flowing again. Our goal is to get every single heart attack patient to the cath lab and get that blocked artery open in less than 90 minutes. So our time starts as soon as that patient walks into the hospital. We are a primary heart attack center here at JPS, which means that we are ready to take any heart attack patient 24/7, 365 days out of the year. And we consistently see about 25 heart attack patients each month. So these are our two most important measures that we report out to Joint Commission. So this first group, or that first white box that you look at, are all of our heart attack patients that arrive from their first arrival to the hospital until we get them to the cath lab and opened up that blocked artery. And then this second group that you look at, that second white box, are all of our heart attack patients who specifically arrive by ambulance. And we call this group first medical contact. And so first medical contact is when the ambulance first lays hands on the patients. So when patients call 911 and arrive by ambulance, response times are faster, processes and protocols are initiated because the ambulance is able to identify that heart attack, and they're able to notify us, which enables us to have heart attacks in patients potentially receive treatment 15 to 20 minutes faster than if they drove themselves. So it's incredibly important that we collaborate with MedStar and other ambulance services to really decrease times and improve our patient outcomes. Year over year, we have consistently improved our times through teamwork and collaboration with the emergency department, our cath lab team, MedStar. And as a team, we review every heart attack patient. I perform a case analysis of every time marker from the patient's arrival to the time blood flow is restored. And most recently, in April, we consistently implemented debriefs with the team after each heart attack patient to discuss wins and opportunities to help improve this measure and to really work to decrease our times. So our heart attack program obtained its initial certification back in 2016. And as Elizabeth mentioned, we have a survey every 2 years, with our most recent being this last June, and it was incredibly successful with no findings. So through this collaborative teamwork, we were awarded the American College of Cardiology Chest Pain MI Registry Silver Performance Achievement Award, which this just highlights the excellence in cardiac care that we provide here at JPS. And if there are not any questions, then I will hand this over to Jess Aguilar.
Dr. Lackawan, do you want to say
As an
anything?
interventional cardiologist, I'm really proud to be associated with the program. It's very well run. We look at every case in detail, and this is sort of a moving piece where things change, and different times they make up that overall 90 minutes. And I think Chrissy and Tabitha, they do a great job in drilling down on every bit of change as we see it. How do we bring this down? So
I have a question. Could you go back to your graph where you, on the program overview, on the patients that are driving? What is the percentage of the patients that's arriving by a car versus the ambulance?
It's about 50-50.
Oh, really?
I have actually been monitoring this since I started this position over the past 5 years, and it has slowly been decreasing the patients that arrive by ambulance, the ones that are driving themselves. And so over the past 5 years, more and more are driving themselves, and we are about neck and neck, 50-50. And actually, this past month, we've just kind of hit that benchmark, more driving themselves. And it's really not the trend that we want to see. So we really try to get a lot of that education out to the community to have them call 911 as soon as they start having any symptoms.
All right, thank you.
It is a concern that we've identified.
Yeah, I was, Trauma did an in-service, and they stressed this about the importance of getting there. I don't remember if they talked about calling the ambulance, but they did go over the symptoms that was critical and showed the difference between women and men.
Yes.
And so that was quite helpful. Okay.
What is your volume? How many of these patients are y'all seeing in a month?
We average about 25 to 30 every single month. True STEMI patients, we get about 85 to 100 a year. So this, the 25 is looking at our non-STEMI type 1 plus our STEMI patients as well. So it's our true total AMI population. But our true STEMI patients, we have about 85 to 100 a year.
Excellent. I want to know what happened in December. It says 0.
Great. Good afternoon. Thank you, Chrissy, for the introduction. I also want to take a minute to introduce my partner, Joe Lawson, who is in the back of the room. He is the other part of the team, as well as Dr. Garrett Johnson, who is our ED co-chair for the sepsis committee. So the sepsis program aims to save lives by reducing the time from sepsis presentation to life-saving treatment. Our most vital catalyst for this is to decrease mortality through prompt administration of IV antibiotics. Mortality actually increases by 8% for every hour a patient goes without targeted antibiotic therapy. Our sepsis program heavily emphasizes educating our patients, their families, and our staff on the importance of sepsis awareness and the TIME acronym, which stands for temperature, infection, mental decline, or extremely ill. If our patients are experiencing these symptoms, we urge them to call 911 or go to the nearest emergency room and tell their providers, I am concerned I may have sepsis. We give the TIME education to our patients in-house as well as our community during events. Our program's foundation is based upon collaboration with key stakeholders to raise awareness of sepsis among our frontline staff while holding each other accountable to the highest standard of excellence as we pursue emerging evidence-based care to promote positive patient outcomes and decrease mortality. We have a very robust sepsis program at JPS with an average of 383 sepsis consults per month, which involve the sepsis team reviewing the charts in real time. So what is sepsis? So sepsis is the body's response to an infection. It is not an infection in and of itself. So if you think about starting a car and using this analogy, the car may be slow to start. Maybe there's an engine light warning on. If we don't recognize the warning lights quickly, or our body's response to an infection and then treat the infection, so take the car to the shop or take ourselves to the hospital, it can quickly progress from sepsis to severe sepsis, where the engine of the car or our vital organs are damaged, or it can quickly cause the car to shut down or the body and go into septic shock, where resuscitation efforts are needed for survival. Any infection can lead to sepsis, but it's essential to distinguish that sepsis is not an infection in and of itself. Our most impactful metric is the Center for Medicare and Medicaid Services CMS SEP1 bundle, the quality core measure for sepsis. The CMS SEP1 is an evidence-based national benchmark for sepsis treatment. The SEP1 bundle focuses on completing sepsis treatment within 3 hours. This measure focuses on timely recognition, early intervention, emphasizing time again as a key driver. The bundle includes IV fluids and, most importantly, IV antibiotics. JPS has an average of 96 patients per month, which is about 3 times the number of severe sepsis and septic shock patients that are reported in the surrounding area hospitals next to us. The national SEP1 average, represented in this graph in blue, is anywhere from 56 to 60%. Texas is represented by the orange bar and ranges from 60 to 64%. I am very happy to tell you that the green bar represents JPS, and this is where we range on our SEP1 compliance from 72 to 77%, and we are consistently above state and national benchmarks. Our SEP1 compliance rate is one of the sepsis program's greatest achievements, especially as a safety net county hospital. We are so proud to share our achievements with you as they truly impact our true north, which are our patients. The steps that have led to the success of our sepsis program are vast, but to name a few, for each service line, we have a physician champion who helps to ensure accountability at the highest level and acts as an extension of the sepsis team at the bedside. Dr. Patar is a great example. He is our sound physician champion and does a great job in being that advocate. We collaborate with our ED critical care coordinators, our nurses, to ensure that those nurses receive a clear and consistent message every single time. We have incorporated recently a sepsis escape room as an education modality, specifically focusing on decreasing mortality and timely recognition of sepsis. We also do nursing grand rounds biannually to bring education to the frontline nursing staff and bring that awareness about sepsis. But the key drivers that have led to the success of our sepsis program, are accountability and teamwork. Accountability is displayed when deviations from best practice are identified for the SEP1 measure. Once identified, an email with the patient's timeline and specific deviation are sent to the primary care team. This leads to teamwork and relationship building with our sepsis champions who are driving our processes at the bedside. The recognition of the sepsis program is vast, but to name a few, we achieved our initial Joint Commission disease-specific certification in sepsis in 2017. We were recertified in 2019 and again in 2022, and as Elizabeth said, most recently this June. It is our glory to tell you that we had no findings in 2022 or in 2024 when we had those surveys. And we have also achieved a 5-star health grade rating for sepsis treatment in 2024, but that made this the 6th year straight that we got 5 years for this. What does a 5-star rating mean? It means that we are dedicated to empowering stronger and more meaningful connections between patients and their healthcare providers. So in 2022, 23, and again in 2024, the sepsis team at JPS wrote Governor Abbott to declare and ask for a proclamation for September to be Sepsis Awareness Month. All 3 years, we received a lovely proclamation in the mail, and in 2024, Texas was the first state to have this signed proclamation. Thank you so much for allowing us to share our sepsis program with you today, and I wanted to hand it over to Dr. Johnson if you'd like to close with any words.
Yeah, I'm Dr. Gary Johnson. I'm an emergency room physician. Jessica highlighted it throughout her presentation, but I do want to emphasize just how excellent our sepsis care is here at JPS. Looking at the standardized averages that you can see in that graph, if you were to have sepsis, you would want your care to be at JPS. We truly do an amazing job here.
Why do you think we see so many more septic patients than everyone around us?
We are a safety net hospital. I think our patients present with more comorbidities that have more long-term management opportunities, and they present later in their disease process. So because of that, we see much higher volumes than our sister hospitals.
Wonderful. I know this has been going on for a long time because I remember worrying about this stuff when I was a resident here, which is ancient history now. So,
thank you for the opportunity today.
Thank you so much.
I would just like to say excellent report. Thanks for the great job that you do. Okay.
And thank you to Dr. Carla Putty and Dr. Badamusi, because this is exactly what we were hoping to get. It's just, we understand that quality happens on all levels of this hospital system, so it's really nice to see how y'all are enacting it in your world. So thank you.
Thank you so much.
It's not happened often that we have. I don't think I've seen this in any organization where an external body comes and in rapid succession and they don't find anything wrong. It's very unusual for this to happen. It's like the Haley's Comet coming year to back, but it's amazing. It truly tells us the quality of the care we provide.
Yeah, I would like to second that. And as an ICU doctor, over the years, I've definitely had a lot of interactions with all of these programs. The most striking thing to me during the survey was all of the surveyors consistently asked, can we borrow this document so we can share with other organizations? You guys are really doing this? How are you doing this? Let's take this. So it's really a lot of credit to them. They've had broad-based impact across the organization, and they all do a fantastic job.
All right, now we're going to move on to QAPI reports.
QAPI reports.
Is this just an update to our current QAPI plan, or?
No, just
what we're doing.
Just operationalizing the QAPI plan. What we have done since this board has approved our QAPI plan. As you can see, this is the QAPI plan that was approved by this board. And since the approval, you'll see the list of committees, programs, and departments with bidirectional reporting to the JPS Network Quality and Safety Council. As Dr. Kalapodi indicated earlier, we will be bringing each and every one of these committees, programs, and departments to you to present a very high-level overview of quality programs within each of these committees, programs, and departments. However, there is also a recognition that a whole lot of these departments and programs are very complex and broad-based. And just like the disease-specific quality programs presented to you now, we will be bringing them here to also give a very detailed presentation to this quality committee. So as our corporate plan demands, we've been having these programs present to the JPS Network Quality and Safety Council every month, and we've had presentations in April, May, and June of this year. And as an example, behavioral health, women and infant, and radiology are some of those very complex, broad-based programs that I'll be coming to present to you in subsequent meetings. So this is a really very high-level summary and overview of behavioral health quality. The metrics that we are reviewing really is just a very high-level overview of some of the metrics that they follow. They follow much more extensive metrics that I'm presenting. So the average days that referrals are in ready to schedule work queue, they have actually done a fantastic job. In most instances, it's less than 7 days, and they are achieving target. The AIP depression response rate has also significantly improved. We started at about 9.4%, and we're currently at about 43.4%. And we monitor this with the use of the PHQ-9 tool. They do have a whole lot of inpatient quality bundle measure that is meeting target. They have 9 metrics in all, and the inpatient throughput bundle, they have 5 metrics, all of which are achieving target. The opportunity for improvement that they highlighted are the percent of patient restraint or secluded. They currently are below national average, currently at 0.28%. The national average is 0.36%. Also, the fall rate, there was a slight bump, and this has since reduced from 2.3 to 2.8. Currently, as of last month, when I cross-checked, it was 1.8 per 1,000 patient days. So they've made some improvement there. How did they make this improvement? They implemented the Observe Smart tool, which is a proximity-based sensor that really ensures that the staff goes in close proximity determined by the department to make sure they actually observe the patient and are able to proactively initiate intervention that reduces the fall risk as well as the need for restraint. Each of the fall event is reviewed by the unit as well as the institutional fall committee, and the data is also aggregated and reviewed for action items. Nutritional services. Nutritional services metrics are listed below, and their number one metric is to maintain health department score. They are achieving targets on these, and it ranges month to month between 97 and 100%. Patient satisfaction is also being monitored, and they're achieving targets in that metric as well as patient satisfaction related to food temperature. Time for referral to outpatient nutritional appointment, they are also achieving target, mostly achieving that within 17 days. And to decrease the percent of abandoned calls in the diet office, currently they are about 5%. The opportunities for improvement that they noticed was they were also earlier on in the year impacted by external supply chains issues, and they also had some storage space limitation and outpatient access. For the external supply chains, they developed a backup system of using disposable if that starts impacting them negatively, as well as proactively ordering of equipment parts, especially those that are reusables. The other issue is with the new expansion, they do have a plan in place to really ensure that all of the storage space limitation that they're currently having will be taken care of during the planned expansion that's ongoing. They've added some telehealth dietitian appointment to improve their outpatient access, and they're also looking at their work queue report closely for opportunities for improvement and discussing with the leadership. They did not report any barriers.
Could I ask you a question before you move from that?
Yes, ma'am.
I understand they are achieving target, but sometimes I question what the target is. And I'm not sure when you tell me on the target for the referrals for outpatient, what is the average time for nationally for you to get a referral? That's the kind of information I would like for us to have so I'd be able to see where we are in that. I know you have targets, but this one, first time, good report. I just kind of thought that might help me understand where we are, because as you get over, I have a question on a couple of them.
Yeah, if our target's like, in 3 months, we'll have a nutrition referral, maybe we should adjust that target, right?
Yeah.
Yes, for the nutritional services, yes, I've taken that feedback and will ensure we do that going forward. And but specifically to your question, the outpatient is 17 days versus national standard of 20 days.
Okay.
So if I'm correct, you would actually bring them back, kind of the trending and the targets in more detail in future dates.
Yeah, that would help. Okay.
Yes, ma'am.
I'm guessing the targets are what we have set as our goal, not necessarily a national standard. Is that correct?
So where there are national standard, I will mention that. Where there are none and we decide to set our own goal, I will also indicate those.
Yeah.
Some are improvement over some. Yes.
And that is one thing I like that you highlighted in the one from the behavioral health, is that even though we are meeting the national standard, we still see it as an internal opportunity for improvement, that it's still not good enough for us. And I love that. And that's the kind of stuff I love to see, is like, even though we're meeting, the rate is 3.6 and we're doing better, we're still committed to making that even better. So
yes,
I agree.
Respiratory therapies, the metrics that was discussed was arterial blood gas average turnaround time. We are currently at 11.1 minutes. The target is 20 minutes. This is also by consensus. There is no firm established national target, so we're actually doing well with that. There are significant outlier. That's what's actually resulting in the 11 minutes, and this really pertains to new staff. So they have intensified new staff training related to entering those results in a timely fashion into the system. The second metric is unplanned extubation in the ICU. This is percent of patients that actually self-extubate prior to the planned extubation, and mostly happen around the time of the planned extubation when sedation is weaned. We're currently at about 1.6%. The national average, looking at all of the journals, is about 10%.
What are you supposed to do to prevent that? Like you say, you're weaning sedation, they're getting uncomfortable. What are you supposed to do? You know?
It just gives us an idea of how we balancing our patient restraint and sedation and early and timely extubation. I think those are the forces interplaying in there. Operating room operation, total cases, there's definitely been an upward trend, and on time starts, they've been targeting 66%. This is an improvement over self-measure. They're currently at about 70%. OR turnover time is currently at about 29% from a prior baseline of about 39 minutes. OR utilization, total utilization for OR is about 94%. And cell saver utilization, you did hear about this from the patient blood utilization presentation that you just got. This is something that is extensively used in our OR. Outpatient day of surgery cancellation, for whatever reason, is at about 7%, and the target is less than 10%. Flash sterilization, current flash sterilization rate is the target is 0.5, even though the AORN does not have any established standard regarding this. So we are improvement over self, and the target was set quite aggressively at 0.5. And the preponderance of the equipment that undergo flash sterilization are those from vendors that do not have ready replacement in our OR.
I see Dr. Webb here, and I see Jessica at 0%.
Yes, Jessica is at 0%.
Information on the vendor.
So sometimes the vendor will bring in specialized equipment that we do not have, usually new equipment that's just been approved that we do not have in the organization. So if it drops and there's no ready replacement, that will be flash sterilized. Yes, ma'am.
When they commented about the Soul Saver utilization, and they reported the improvement on cost with using it, does that include the cost of the Soul Saver itself when we're showing the cost reduction? Do y'all know the answer to that?
I'm not sure, but I think so, and I can find out and get back with you on that.
Yeah, I know, because if the Soul Saver is costing us, and I think we need to be preserving blood, don't get me wrong, but I'm curious to see how expensive the Soul Saver is, because if it's that good, get it in all the units. With my endless budget, Dr. Duncan.
Because we know what it costs us to get blood.
I know, right?
We can get more information and follow up on that for sure. I think there's a fixed cost to the equipment itself and the technologist, but then I think it's equipment that keeps saving us over time. So it's a one-time investment that kind of pays over time, but I think doing a financial analysis to see the true delta would be helpful. So we can do that and bring it back.
Thank you.
Hospital throughput. Despite in the last several months that we've been having a lot of high volumes in JPS, our mean length of stay continues to go down, currently at 5.6 days from a baseline of 0.9 days. And discharge orders by 10 a.m. is 35.9 from a target of 35%. The median bed request to ED departure to the wards is 118 minutes with a target of 120 minutes. Nationally, this benchmark target is 180 minutes. Turnaround time from order to completing the study is 495 minutes from a target of 600, and EVS turnaround time for room cleaning is 54 minutes, which is essentially same as the target of 53 minutes. Medically cleared arithmetic mean length of stay is 160 hours. These are patients that have been cleared for discharge but are still boarding in the hospital for one reason or the other. Then physical discharge by noon, which means patients have left the hospital, is at 17.15%. All of these metrics are achieving target except number 6 and number 7. Number 6, there's an ongoing work to close the gap. This number or this average is significantly skewed by outliers. And this consists primarily of special population of patients that we are paying a whole lot more attention to, especially from the correctional facilities, because there has to be increased coordination between us and the correctional facilities. And there is a level of clearance, a different level of clearance that is required to transfer those patients back to the correctional facilities. The throughput committee has actually been doing a whole lot of fantastic job in addition to keeping the length of stay low, they've also been keeping close eye on readmission so as not to avoid the risk of pushing our patient early and only for them to come around. And we see both numbers actually trending in the right direction. Other programs that have been implemented has been the discharge lounge. These are patients that have been ready for discharge. They will be transferred out of their room to the discharge lounge to wait there, but they are still in the system. But the room can be cleaned and made ready for another patient to occupy, as well as meds to bed to ensure patients actually get all of their medications prior to discharge.
How long are they staying in that discharge lounge after you take them? They've been up there, then they move there. What is the average time that they are staying in the discharge lounge?
I don't think there's a set time. We can definitely bring back an average.
Okay.
But we actually expanded how we use the discharge
lounge. We're letting patients go down there if they're waiting on their last antibiotic dose or last medication administration, and so they can be down there for quite some bit. It also depends on their ride, especially if we're waiting for a family member to get off work in the evening time, or historically it's kind of a laster. If they're going to go be a MedStar, for example, it's considered a non-urgent request, and so they come later in the evening as well. So it really depends. I mean, if their ride is imminent, we really don't send them down there, but it's a great way to send patients there because they get, there's a couple of nurses there, they get really extensive after visit summary information, patient instructions, they can get a flu shot while they're down there, they can get several things taken care of, get appointments made and things like that.
Okay, all right. My question was on the turnaround time for the MRI. 600 minutes is 10 hours. So, am I reading that right?
What's the definition of turnaround time?
So turnaround time is from when the order is placed till the order is completed. So there are several factors that can contribute to that.
Okay.
Some of these patients, because of the claustrophobia associated with MRI, some of them require anesthesia. That also get captured in those time. And most of the studies are non-emergent. Some of those patients are coming from outpatient. So there's a lot of preparation that needs to be done to that.
All right, so this includes outpatient too?
Yes.
All right, okay.
Also, I mean, just from my experience, sometimes we do the non-emergent overnight.
Correct.
Yeah.
So that it opens the MRI for the daytime traffic.
It
so.
would appear to me that I would pull those out so that your turnaround time would go down. I mean, it's, if you're doing it at the inpatients, their turnaround time probably is a little bit different than the outpatient. So I just kind of saw that as long, but I'm okay.
I'm wondering if we can change the definition of medically cleared for those, like you mentioned, the behavioral and the correctional facilities. If their definition of medical clearance is different than what we're using, then truly we probably don't need to medically clear them until we meet that definition. I think that alone would probably decrease that 160 hours. I mean, that's a huge gap between 160 and
It's still a good metric for us to watch, though, because we really work with our partners, like in behavioral health and correctional health, as well as our behavioral health patients who are going to their next site of care, and we're having trouble getting them discharged or finding the right site of care. It is important to still track them very closely because those are the ones we need the most eyes on and the most attention to. And so it would help the metric, I guess, but it's also how we pull reports. Medically cleared is how our case management team works the list of patients that we have as well. So there's pros and cons.
Yeah, to add to Jill's point, we have decreased length of stay by 1.3 days in about 9-10 months. That is impressive work. Now, length of stay is also a function of what happens between the hospital and the external world. So I think this metric is actually trying to figure out how can we influence our partners in order to actually create capacity in-house. So I think having individualized measures to actually look at subset will help, but having an overall measure actually will help us understand how is that interface working? How are our partners working with us to create the capacity? Because we are the only safety net hospital in town, so we need the capacity to take care of patients. So I think that's a measure that captures the thing, but we can have subsections to measure what truly we control that we can get better at.
Yeah. So we could have them medically cleared, but there's no room at the SNF, or there's no room at the, is that what you're kind of saying?
Yeah.
Is medical cleared really discharging? Or medically cleared mean you're ready to be discharged from?
Medically cleared, if you wrote an order and I had somewhere to send you, then you're good to go. Yep, you are medically cleared to go to your next site of care.
Okay, all right.
They don't have to be better.
No, I'm just wanting to make sure that this is the time you are ready to go home or go wherever, and that's the time it's taking us to get them out. I just wanted to be sure. Okay.
Thank you.
Thank you.
Next, we have the women's, right?
Women's. Women's is one of those very large departments as well, and with a lot of metrics. This is really a very high-level overview of their metrics, and they will also be coming in subsequent meeting of this board to provide in-depth presentation. Use Uterotonics for patients with high-risk PPH is at goal at 72%, and there is no postpartum hemorrhage. Yes, postpartum hemorrhage. Thank you. And this has improved with the with improved screening, and of course with also the multidisciplinary OB-QAPI plan, that meeting that takes place every month and sometimes even every 2 weeks as needed, where each patient is reviewed and plan is developed. Plan of care is developed. Provider response to urgent request to bedside of less than 30 minutes. This is actually 100% in reality, but there's documentation issue in the way the data is captured, because the nurse has to actually enter the time that the patient comes after the provider responds and arrives after their call. Sometimes the unit is so busy and everybody is all hand on deck, and if they don't enter it real time, there's no way for the data to be captured. But in-depth look at this shows that in about 11% of cases, the data is not being captured, and if you add that to the 88%, it's 99%. Strict I's and O's in patients with pre-eclampsia on IV magnesium. This is currently at 53%, but it's trending in the right direction. There are other modalities to monitor for toxicity of this medication, including deep tendon reflexes as well as blood level of magnesium. But so long as they have good urine output and we are keeping a close eye on that, they are unlikely to develop any toxicity. Sepsis, antibiotics, receiving antibiotics within 30 minutes. This is a goal that our OBE actually imposed on themselves, a very strict target. The national requirement is for antibiotics to be administered for maternal sepsis within 1 hour, but they were achieving 100%, and they decided to move the bar and lower it to 30 minutes. When I actually looked at an updated data, they are currently achieving 100%, even on this 30 minutes metric for the last 2 months. Screening for placenta accreta. This is placenta accreta is situations where the placenta grows in too tightly into the uterus, and of course it's difficult to deliver, and it's associated with a lot of bleeding. And this is at 84%. However, the current data is about 100%. It's 100% achievement in the last 2 months. Again, this is really thanks to the multidisciplinary OB-QAPI team that actually identify all of these patients during the antenatal period and develop individualized specific plan of care for those patients. The part of the action plan is to actually, they've deployed a new handoff tool to ensure that as patient is moving from the wards to the labor room, or for patients that are in the labor room going to the wards, that there is specific point where each nurse will have to hand over the intake and output, the urine output for the patient as they are moving around, so that the magnesium I's and O's can be monitored closely. And if there's any concern, additional interventions can be initiated.
How are they screening the placenta accreta? Just by ultrasound? Is that what they're using? Okay.
So that it's a patient side and the inpatient side.
Okay. If they hadn't had great prenatal care, you just go based on what the ultrasound is showing, or?
We still do both.
We still do
yes, ma'am. Mm-hmm.
And how do you manage them differently?
They go on our critical, let me turn this on here. They go on our critical care list to begin with, so that everybody's aware. And then on admission, there are additional measures taken, such as blood on hold, having the blood cell saver. We have a consultation service with multiple specialties such as ICU, oncology, urology that are on hold for those cases, so that if we have to call them in, they're immediately available and aware of what's going on. Yeah,
that system really works remarkably well. I There was the last patient I remember, because I'm part of the MFM ICU cooperative plan, actually received the highest volume of blood transfusion I've ever seen in my practice, and everybody worked together, from general surgery to urology to interventional radiology to blood bank. So it's a really well-established system. Infants, again, urgent request to bedside, they are achieving 100%. Infant code, they are compliant 100% with the code guidelines for infants. And the screening for retinopathy is at 100% achievement as well. The radiology turnaround time has been 100%, and the blood bank turnaround time is 100%. Echocardiography turnaround, less than 2 hours, is currently at 40%. This is performed by JPS technicians and is interpreted by Cook's children. There is ongoing work at really live streaming real images, and the 40% does not tell the complete story of this metric, because the average time currently is about 2 hours, 14 minutes, and they've been steadily decreasing. Year to date, they've had about 13 patients, so even one patient can skew the whole data. But it's a metric that they're still working on, and hopefully with this work, once completed, to live stream images real time as the technician is obtaining it, that should improve the turnaround time. Contract management has also presented to the committee, and as of the time of their presentation, there are a lot of contracts that they review, and they've reviewed 76 as of that time. More have happened since this presentation. 65 of those have had clinically direct. They've had direct impact on clinical care, and 11 has had indirect clinical has clinical indirect patient care contracts.
What contracts are you referring to?
So, for example, the pharmacy contract mixer, that's direct. EVS, language line, that will be indirect patient care. Yeah. So the system they've developed is to systematically evaluate all of the contracts to ensure that they meet general requirements, then specific metrics that the contracts get evaluated upon, to make sure that all of the KPIs that the organization established, that they are meeting those at intervals. And if they are not meeting, just like one direct contract for translational service did not meet established KPIs, and the contract was not renewed. So they are held accountable for those KPIs, and once it's reviewed, and there's a cadence that they've established to review all of those contracts to ensure that they are meeting all of the KPIs that was agreed to.
So I think this was an ask on the board, and so it's really great to see that these contracts are being reviewed.
Antimicrobial stewardship, this program really looks at, is a TJSA requirement as well as CMS requirement that we have this, and it's very robust here at JPS, and it looks at how we're utilizing our antimicrobial agents and how we're managing resistance pattern. The standard metric that is used nationwide, it is the standardized antibiotic administration ratio. If that number is 1, it means we're using the exact amount of antibiotics that we're predicted to use as an organization, and we are not overusing. So we are currently at 0.91, and the quarterly breakdown is 0.965 and 0.998. The other requirement actually that we've adopted as a metric is a TJC standard that requires us as an organization to develop 2 clinical syndrome specific guidelines, which means we have to develop for community acquired pneumonia, which is one of the guideline that was discussed. We look at the best evidence available in the country based on all of the standard guideline. How does it apply to us? What is our antimicrobial pattern? What would be our first line treatment for pneumonia? What what would be our alternative, what regimen based on our antimicrobial data is contraindicated. So this antimicrobial stewardship program developed those guidelines and they post it and make it available to all providers, so to guide antimicrobial selection. The second one is a sexually transmitted infection guidance in progress. As a member of this stewardship program as well, that was just voted on and approved this afternoon, just before this meeting. So we have the guidance available for providers to assist in antimicrobial selection. The active barriers that they've indicated is the need for automation of antimicrobial data. A lot of their processes is currently or are currently automated, but there's an aspect of improvement that they're engaging on, which means they want to look back at the billing data to see patients that come into the hospital with pneumonia. Okay, look back, did they get the right antimicrobials during that admission? If you bill that they have a pneumonia, that's an indication they truly have it. Now let's go back and look at the antibiotic selection and how compliant are they with this CAP guidance. So in collaboration with the CMIO, the antimicrobial, the pharmacy IT person, and 3 clinical pharmacists, as well as the director of antimicrobial stewardship, we are actually building that system to enable automation of this data so that we can provide real-time feedback to providers, as well as learn on our pattern of antimicrobial use.
I think this is excellent, especially in light of what we were talking about with the sepsis program. One of my concerns when you hear that we're doing 3 times as much as anybody else is, are we overcalling sepsis and overusing antibiotics in those cases? And so, I didn't hear it specifically in what you're saying, but seeing our rate is pretty, on target, and there's all this review going on. Hopefully they're kind of watching how much we're overcalling sepsis as much as we're appropriately diagnosing it and treating it. So.
Yes, ma'am. Radiology. This is also a very big department and are currently scheduled to be presenting before you in subsequent meetings as well, because they collect a whole lot of metrics and they have certification through various programs as well, and they will be presenting to you. But the ED studies turnaround time, the MRI safety metrics, the STAT stroke CT result, as well as radiation dosimeter compliance are all at goal, and they will be here to provide very in-depth data to you as well. External quality reporting.
So as far as these go, how often are we going to get like updates on these particular ones? Like next quality meeting, we're going to cover different ones, I'm expecting, right?
So all of these programs are kind of like the current cadence is for them to present to the JPS Network Quality and Safety Council twice a year.
Okay.
So with all of the feedbacks we're getting from here, we will get it across to the various departments and we will bring this presentation back to you. So my expectation is once this process gets really established, we will be bringing this back to you twice a year, or again, as determined by you. If you need us to bring a program back more frequently than that, we'll do that.
Sounds appropriate.
If we do it more, that means you've got to have more meetings.
Yeah, okay. This is fine. No, I just, obviously we're meeting so many of these targets, but.
And we've talked about it.
Yeah.
We're, there are a few things, and maybe we can just, if there's movement on those, and positively or negatively, we can bring those up, but don't have to go through all of the ones we're doing well every time.
Yeah, I think if they're bringing them back twice a year, there'll be more trended information. And as they are looking at it monthly, anything identified, they would probably bring it to you at the next meeting. I mean, that's my thoughts.
Yes, those are good thoughts. External quality reporting.
So we not only look at our own internal metrics that we established for ourselves, we also want to make sure that external quality metrics that are from other organizations, either regulatory or financial, with financial impact, or that are required by other organizations. How do we stand compared to other organizations? We also report those, and we thought it was appropriate to bring those before you and share as well. So the first program is the preventable adverse event. This is required by the Texas state law, and it is publicly available. It is reported to the Texas Healthcare Safety Network. There are 7 event categories, and there are 33 event types that we'll report on as listed below. So this is the detail slide, and you can see the categories: surgical or invasive events, patient protection events, potential criminal events, product or device events, and care management events. For the surgical or invasive events, FY to date, we're currently at 0 for all of those complications. For patient protection events, this is inappropriate discharge, we have 1. And for sexual abuse or assault of a patient within the health care facilities, we have 1. Product or device events, 0. And the biggest event that we're having is HAPI, which is stage 3 or stage 4. We currently have 4 of those FY to date, and 1 hypoglycemic event.
What does HAPI stand for?
Hospital-acquired pressure injury, or healthcare-associated pressure injury.
We have the new technology for that. That should improve, right?
The leaf.
Have the turning timer.
Yes. Leaf, yes.
Yeah. Okay.
Here are some of the action plan from the organization in terms of what we've been doing, and it's really conducting regular audits and documentation and communication to providers and nurses regarding opportunities identified by the wound care team that round daily on these patients and develop assessment and intervention plans. These are all presented at the wound care multidisciplinary monthly meetings. Poor glycemic control. Anytime we have hypoglycemia, it is investigated, especially if it meets the CMS qualifying definition of hypoglycemic event. We do have a glucose management committee, and that reports to the medication management committee. And we're actually working at converting this process to become more automated using the CMS-defined ECQM, so we'll be able to pick it up directly from the EMR as well, and develop a robust action plan around those. These are really very rare events, fortunately, but the goal, as always, is 0. Patient fall with severe injury, and again, there is a unit-based fall review committee that reviews every single fall, as well as reporting out to the institutional fall committee that reports to the patient safety to get a bird's eye view of the situation and the prevalence of fall across the organization. So we do have individualized patient-specific action plan for all of this fall, as well as broad-based review of our fall prevention measures organization-wide. The other external program is CHIRP. CHIRP is a directed payment program, and it's primarily is a state-managed program that is primarily focused on the STAR and the STAR Plus Medicaid managed population. It is part of the district transition plan that was approved by CMS. There are 3 components to CHIRP. The component 1 is the Uniform Hospital Rate Increase Program, and there's a little bit of a play with word here. They call it Europe, Asia, and Africa.
Man, how did they get so clever?
Yeah, so there is component 1, component 2, and component 3. Component 1, the Europe component, is actually a condition of participation. So we have to do that. We have to submit it. And component 2 has just been made also a condition of participation, even though JPS is not eligible to receive this Asia award because we are already above 90% of our average commercial payer for Medicaid, and we are still required to report the data, and we do have the data. Component 3, this is one that is kind of like pay for performance, and it The underlying issue with component 3 is a quality metric. It's a lot of quality metrics that we have to submit to the state, and the intent is quality. But there's also a significant financial component to this, that if we achieve the benchmark and the metrics set by the state, the hospital will get there's a financial incentive that we can earn. So they've established some goals, and they've established some criteria for us to meet these measures. So there are different types of goal calculation. There is benchmark and there is improvement over self. They want us to look at the cesarean section rate, readmission, and post-op sepsis. And for the improvement over self, it's food insecurity, flu immunization, as well as safe opioid use. We are due to submit our baseline data to the state in October of 24 and our submission in April of 2025. So in current state, we have a multidisciplinary committee that is actively working at ensuring that all of that we achieve in all of these goals, that we achieve the overall goal as well. And we do have project-based intervention addressing readmission and NTSV cesarean section. So basically what we are doing is, with this population, with this vulnerable population, looking at the big projects, looking at all of the intervention that we're doing, we just didn't want a one-off. We want to make it in a project form so that all of the lessons learned we can actually apply to all population that we take care of in JPS, and develop evidence-based methodology to actually study the problem, study our intervention, ensure it's working, and ensure we actually achieve these metrics. And we're also collaborating with local resources and connecting our patient as part of the food insecurity program to local resources, which is required by this program as well. So we will be bringing back this program once we collect all of the data just prior to submission.
And Rory, remind me, we budgeted to have 100% achievement, is that right? Okay.
About 11 million.
I'm curious at how we're supposed to measure some of this, like the food insecurity. How are we supposed to measure that our patients are no longer insecure, you know?
It's really interesting. They do have specific way they've recorded. So hunger has a vital signs, 2 questions at intake for every patient. And if they screen positive, the way we currently have it, and that was approved by the state, is their AVS gets a QR code that refers them to the Tarrant Area Network Food Bank. So they can actually get connected to the resources. So they get asked this question. And we do have an opportunity throughout the year to be able to make sure that any of our patients that screen positive for food insecurity gets connected to those resources.
Yeah, it's more like intervention. Okay.
And of course, this is a kind of like ongoing monitoring for our CARDI. We continue to do well. We went a period of over 96 days without CARDI, over 3 months without CARDI. We've had 1 or 2 since then, but today is 28 days since our last CARDI in the organization. Again, we are counting, and every single unit we've implemented days since last, so that everybody will know that this is what we're doing. It was indeed a very unhappy day when we diagnosed our first CARDI after somebody broke our genes.
Over 100 days. That's pretty good.
So for CLABSI, we continue to do well, and there's a multidisciplinary team that looks at our CARDI and CLABSI. These are really very important just because they impact a whole lot of programs. Surgical site infection, this was significant areas of opportunities in the past. We have come down significantly, and we continue to do well as well. This is for abdominal hysterectomy. We continue to do very well. And these are some of the action plans that we have for CARDI and CLABSI. Really is to make sure that do we really need any of these catheters? If we don't need them, let's not place them or take them out immediately when they're no longer needed. Focusing on dressing integrity has also been a major action plan, and we've updated our clinical decision tool that really added hard stops. So you can't just order urinalysis on a patient with Foley catheter. It will ask you why, and you have to really provide a justification to be able to do that. And we have a surgical site infection work group that has been focusing on documentation and perioperative antimicrobial administration, chlorhexidine bathing, as well as blood glucose control to minimize the risk of surgical site infection. For our post-op complication, we do have a PSI task force that review every single case of post-op complication to ensure it's appropriate or if it needs to be referred for further review. And this is done in collaboration with our surgical colleagues, and we get our data primarily from the claim-based data, and we analyze those on an individual patient basis and provide the detailed information about this to our surgical colleagues by way of feedback.
Excellent.
Patient safety.
Dr. Fatamusi, do you need something to drink or anything?
Pardon me?
Do you need something to drink?
No,
Yeah.
yes, ma'am, I'm good. Thank you. Thank you. So some of these we have brought to you before, but I feel I should highlight them again as I will be making a lot of reference to them in our subsequent presentation. How do we manage our patient safety event? Anytime we have a team member document a risk event in our error reporting system, which is MIDAS. This is analyzed by our patient safety consultant to determine whether or not there was any deviation from generally accepted performance standards, and if there is none, it is classified as not a safety event or a known complication. If there is a question of whether or not did the deviation reach the patient? Was the patient harmed by this deviation? If it's no, then it's a near-miss event. If it's yes, did the deviation cause moderate to severe harm or death? If it's no, it's a precursor safety event. If it's yes, then it's a serious safety event. So there's a systematic, objective process that we have in place by our trained and certified patient safety consultant to analyze every risk event that is documented in MIDAS. Then the process moves on. This is what I've described. So if there is a need to refer to peer review, it is referred for peer review, and that is dealt with in that context. However, if there are any system or systemic issues identified, it will further be analyzed to determine whether we need an RCA or an ACA to further analyze it in detail. And both processes can proceed simultaneously on the same case because sometimes there is a provider issue as well as a system issue, such that we can deal with both adequately. And this is a summary of how we classified. This is based on the HPI SEC classification. This is a national methodology, and we classify it as serious safety event. There are 5 classes of those: precursor safety events and near-miss safety events. Now, the metrics that I'll be presenting to these boards include sentinel events. And there probably will be a change in the way sentinel event has been described. I will refer to that I will explain what I mean by that shortly. Then there is serious safety event class 1, serious safety event class 2, serious safety event rate, Medsun and MedWatch report. So sentinel event, as we all know, means something that should not happen, something has gone wrong, and any patient safety class can be a sentinel event. We follow the Joint Commission list. Now, there's an update since April of this year. The National Quality Forum have really become affiliated with the Joint Commission. So there may be a change in terminology. They'll provide an update later this year. So I may say serious reportable event at our next meeting, but it's the same as sentinel event, and I'll be sure to highlight those as well. Serious safety event class 1 and class 2 Again, type 1 is a deviation that results in the death of the patient. Serious safety event class 2 is permanent harm. When any of these happen, we initiate an immediate risk reduction. This is with the senior leadership of the hospital. We all sit down at a meeting and develop a plan to make sure this does not happen to any other patient. And we initiate an RCA2. We have the 3-meeting process, and this is reported ultimately in summary fashion to the patient safety committee. Now, serious safety event rate. Overall goal of our safety program is zero harm to the patient. And the way we will be monitoring that is our serious safety event rate, looking through all the 5 classes of safety event and adjusting this for per 10,000 adjusted patient days. There is no national benchmark for this. And as you can see clearly, based on the definition, it will depend, this number can go up just because people are reporting more. And it can go down because people are reporting less. So it will need to be interpreted in context. And this number is adopted by a lot of organizations and is being championed by the AHRQ as well as Press Ganey. It is calculated as number of serious safety event class 1 through 5 in a defined period divided by the total adjusted patient days in the same period times 10,000. So this is basically an improvement over self with interpretation required in context depending on the volume of reporting that we're seeing. Then there is the medicine reporting. This is an FDA reporting mechanism that we as an organization report events to the FDA, primarily related to devices, malfunctions, failure, adverse events, product problem, or any design flaws that is recognized. This is the portal that we use to report, and we'll also be bringing that to you for your awareness. MedWatch is primarily related to medication, adverse events, side effect, or quality issues, or any other issues that we're observing. And this allows the FDA to put this together in a cumulative fashion and provide advisories to organizations. Any questions?
Wow. I mean,
a lot of information.
Yeah, it's been amazing having Dr. Batamusi step into this position. He really does eat and breathe quality up very early in the morning. Gets he quickly, he has any concern, elevate it very quickly. And so I just want to thank him because I know he gives us all here comfort to know that you're overseeing the large amount of quality that goes on across the hospital. So thank you.
I just want to say it's an excellent report. It's a lot of information, but it's meaningful information. So thank you.
Thank you, ma'am. Thank you.
I think we have some items for close. Yeah, we
do have close.
Okay. Anything to add before I move to close? I will close.